I want to acknowledge that we're hosting this session on the unceded ancestral territory of the Coast Salish peoples that includes the territories of the Musqueam, Squamish, Tsleil-Waututh Nations, and the Métis Charter community of the Lower Mainland region. That each of you should acknowledge the location in which you are hearing this and understand more about that location as well. Next slide. So it really gives me a great pleasure to introduce Dr. Gaylene Hargrove. I know many of you know her, but she, for background, attended medical school at the University of Calgary and completed her residency in medicine and nephrology also at the University of Calgary. And she's been in practice in Victoria since 1999. And importantly, she completed additional training in palliative care for renal patients and has been an advocate and avid educator with respect to opportunities for island health and provincially. She's been a member of the BC Provincial Palliative Care Committee for 15 years and has recently been appointed chair. And so really pleased to have Gaylene on behalf of the BC Palliative Care Committee help us on this day in November to appreciate where we are and where we're going in this province. So Gaylene, thanks again very much to you and your team for all the things that you've done. I'm looking forward to hearing about it. Over to you.
Thank you very much, Adira, for the kind introduction. So the title of the presentation today is Integrated Palliative Nephrology in BC, and there are many of you attending our presentation today who have heard this terminology before. And really today will be about distilling the last 15 years of very hard work by many, many people. I unfortunately do not have time to acknowledge all who played an instrumental part in this work, but I will try to pay tribute along the way. Current state and what's next, and I am presenting on behalf of our Provincial Palliative Care Committee for BC Renal. Next slide. I acknowledge that the land on which I'm presenting today and on which I live, work, play, and learn is the unceded and ancestral territories of the Lekwungen-speaking people of the Songhees and Esquimalt nations and Saanich peoples whose historical with the land continue to this day. I'm very grateful and honored to have the privilege to reside on this land. Next slide. So by way of overview, and I won't repeat the objectives, you have had a chance to review them, which were distributed prior to the presentation today. So I'd like to speak to the end-of-life framework for those of you. I'm speaking about trainees, perhaps new to working here in BC, and others who may be new, just to summarize our end-of-life framework and what work we've done beyond it. As part of that framework, we have advanced care planning, symptom assessment and management, grief and bereavement, pardon me. Those are 3 of the 4 pillars of the end-of-life framework, and I'll expand upon that. I'll just describe our lessons learned along the way and a summary at the end. Next slide, please. So our end-of-life framework was developed in the, we started to develop it in the mid to late 2000s, and it was published, I believe, in 2009, and I will be presenting our timeline. Next slide, please. And so really, this is what we're looking at in terms of the journey of our patients along the trajectory of CKD. So early on, we have the diagnosis, and there's focused disease-specific therapy. This may be directed towards the primary cause of the CKD, be it glomerulonephritis, be it diabetic nephropathy, and we've had the privilege to learn about some new and exciting therapies for diabetic nephropathy. So this is our focused therapy here. Notwithstanding, though, there's an opportunity to participate in advanced care planning early on. And that's what we are advocating for, because after all, they are now diagnosed with a chronic illness that is unrelenting and not fixable, so to speak, even with a kidney transplant. So with that realization, as they move along in their illness journey, we want to identify those who could even more than early on benefit from a palliative approach. And I'll describe what a palliative approach is. And along with that, there's a symptom burden as patients move along to more advanced CKD. And we want to participate in asking about these symptoms and helping to manage them in collaboration with other members of their care team, including primary care physicians. And then we hope that we can identify those who are nearing death and support them and their families as they get closer to that point. And there's some challenging decision making along the way, and our role is to help support them in these difficult decisions and providing care that is to optimize their quality of life. That's the focus. And really what we're talking about approach is to find out what matters most to the patient. This considers the physical, emotional, and spiritual concerns of the patient and addresses their hopes and fears. Our care is respectful and supportive of patient dignity and autonomy. And really, our treatment plan must align with patient wishes. But it's difficult to align our management if we don't know what the patient wishes are. So we have to ask. If you don't ask, you don't know. Next slide, please. So we're a remarkable journey, and I must pay tribute to Dr. Mahmoud Karim, who has been just a very significant mentor for me and truly an inspiration. So in 2004, 2005, there was formal engagement and discussion around renal palliative and end-of-life care in our renal community. And in 06, 07, there was a development of guidelines and plans within health authority renal programs by what we called an end-of-life working group. And then in 08, 09, this was the publication of our end-of-life framework describing the 4 pillars. And then in 2010, 2011, we formed our provincial end-of-life steering committee, and that coincided with advanced directives that this gained legal status in BC. So all of this was quite timely. And then we knew that we couldn't just publish this end-of-life framework and expect that there would be uptake and implementation. So we developed, to support this work, we developed and implemented education strategies for the 4 pillars, that being patient identification, advanced care planning, symptom assessment and management, and grief and bereavement care of the dying patient. Next slide, please. So carrying on, we then, along with, thanks to our pharmacy and therapeutics team for BC Renal, led by Sin, there was a publication of protocols and algorithms for symptom management. And I use these algorithms to this day. And last night I participated as a facilitator in a workshop for family physicians and palliative care physicians, approximately 40 across Vancouver Island. And they were eager to learn about resources on the BC Renal website, and very pleased to hear that they have a go-to for support in that manner. So the End-of-Life Care Action Plan for British Columbia was then published by the Ministry of Health around that time in 2012, 2013. And then there was the establishment of the BC Centre for Palliative Care. There were training modules for symptom assessment launched online. And then subsequently in 2014, 2015, there was the formation of a research working group to address knowledge gaps. Helen Chu conducted an environmental scan to review progress for strategizing improvements in renal palliative care. And then along with that, in terms of advanced care planning, there was publication of It's Time to Talk, which was a policy paper by the doctors of BC. And then 2016, 2017, there were many ongoing activities, primarily related to the development of quality metrics for renal palliative care and implementation of advanced care planning module on PROMIS. So this is how we capture data, and this is then an objective way to assess how well we're doing with advanced care planning. And likewise, there's the symptom assessment and management module, which helps track how well we are actually implementing our tool, and I'll talk a little bit about that. But we use the modified ESAS Renal tool to collate data around symptom burden. And we also collated advanced care planning videos, and you can view those on the BC Renal website as well. And then in 2016, 2017, there was the release of the first palliative care indicator report. We also developed and published the conservative care pathway guideline in collaboration with the Kidney Care Clinic Committee. There was update of symptom management resources around that time. And then coinciding was the implementation of the Serious Illness Conversation Guide across BC. And that is a very significant tool that we use for guiding conversations around advanced care planning and really getting to know what matters most to the patient. And 2018, 2019, another environmental scan to understand current practices related to integrative palliative renal care. And then we also released recommendations to support end-stage kidney disease patients in their last days to hours of life, rather. Next slide. And there were 2 publications in 2017, very proud of the work that went into seeing these to fruition. So there was a survey of nephrologists across Canada assessing prognostication in end-stage renal disease, and that was published in the Canadian Journal of Kidney Health and Disease. And then published in Palliative Medicine was external validation and clinical utility of a prediction model for predicting 6-month mortality in patients undergoing hemodialysis for end-stage kidney disease. And I'll pay tribute to all of the authors listed. This was truly groundbreaking work, and we're very, very proud of having the opportunity and privilege to participate in knowledge translation in this way. Next slide, please. And really, Helen deserves a crown, really, for a badge of honor for seeing this publication through. So this is entitled Advancing Palliative Care in Patients with CKD from Ideas to Practice. This is a perspective paper that has just been accepted to AJKD, and it is a comprehensive, excellent summary of the work we've done over the past 15 years, more importantly, how we've implemented that into the routine care of the patient living with CKD. Next slide. And some of you will have already heard about our integrated palliative nephrology project, and I want to acknowledge Sarah Thomas at this time. So she was our project manager, is our project manager for this. It's ongoing work. And the purpose of this project, which Sarah and I presented in detail in March, in fact, as I reflect, that might have actually been one of the last in-person provinces where we pivoted, made a very dramatic pivot to online presentations solely. But we sought out to develop and implement a provincial strategy to effectively integrate a palliative approach for all patients with CKD under the care of nephrologists across BC. And we identified 4 components in terms of deliverables. That being education around the serious illness conversation. You can read for yourself all of the various venues that we sought out for opportunities for knowledge translation. And really, in terms of true implementation, we realized it's critical to train champions, those who are truly passionate about this work in each health authority, and to spread the word that way. So we've had ESAS Promise Module training, as well as advanced care planning Promise Module training. In terms of dissemination and culture change, we forged partnerships with hospice programs across BC, Division of Family Practice, and the BC Centre for Palliative Care, and the First Nations Health Authority. We developed documents, and our patient partners on our working group were instrumental in assisting with this work. We published the Preparing to Stop Dialysis documents and transitioning to conservative care, and as well as ACP tips for renal clinicians. And this is ongoing in terms of evaluation. So we want to know, we want to measure if we've actually accomplished what we set out to do and how well we've done it. So pre-project, there was an environmental scan, a survey that was broadly distributed. Mid-go, there were chart reviews and patient interviews in each health authority. And we're in the process of trying to develop a new strategy for performing post-implementation evaluation and the best timing thereof. We have to acknowledge that there has been a challenge imposed by the pandemic in this way. So it would be very difficult to physically go and perform chart reviews in each health authority. So we're coming up with some creative ideas as to how to conduct this in a different way. And in parentheses, you can see listed the various meetings and whatnot that we've been able to present our work in the way of posters and presentations. Next slide. So next on to advanced care planning. And so really to describe our goal in this way is to ensure that patients and families understand their health issues. So those of you who are familiar with the serious illness conversation, the first line of questioning is around that understanding piece. What is your understanding of where you're at with your illness and with where your health is at this point? And it relates to applying the patient's key priorities in their care. And this is aligned with provincial and health authority efforts. As you can see from the timeline, the Ministry of Health is very interested in this work, and they've played a role along the way in terms of, you know, for instance, establishing the legislation for advanced directives. So, and the ministry helps support the BC Centre for Palliative Care, for instance. So all of our work is aligning with other provincial strategies. There are video guides for MDs and staff as to how and when to initiate the conversation with patients and their families. I mentioned the ACP module for the data capture. And this is just a screenshot of the ACP module here. And of course, again, the serious illness conversation guide, training and resources. And so ideally, all renal care clinicians should be equipped to participate in advanced care planning conversations. What our environmental scan has shown is that in most cases, the social worker in each health authority renal program has been the key facilitator in these discussions. However, really, all of those of us who have been doing this for some time realize this is a team effort. And the timing of initiation will vary depending on patient factors and other factors. And we'll talk about COVID-related factors in a little while. Next slide, please. So we wanted to come up, and this was in response to feedback we received from around the province related to the question being, when is the best time to initiate a serious illness conversation? Well, you know, the answer is there are many opportunities, and our goal is to push the timing of the first conversation upstream, so that what we want to avoid is the situation and scenario where the first time you're having an advanced care planning discussion is a week before death. So this was devised again with input and feedback from our patient partners, entitled Starting the Conversation, Exploring Key Concepts Throughout the Renal Journey. And we identified, you know, 5 main categories of where there might be somewhat of a fork in the road. There's decision making. There may have been what we refer to as a sentinel event that would trigger a conversation. So when the patient is being seen in the nephrologist's office and or through the kidney care clinic, and they're being presented with options regarding renal replacement therapy. And that is certainly a good time to discuss goals and preferences. And you ask permission. This language is actually patient validated. This was vetted by our patients, and they really appreciated the fact that we were asking their permission, because, you know, maybe it's not okay. Maybe they're just not ready at that point. And every patient is different in terms of their state of readiness. Certainly at the time of dialysis initiation, this is a critical time to know what their hopes and fears and understanding of their illness is at that point. I'm sure many of you will have experienced a situation where a patient feels as though dialysis could keep them going for decades, and you know, a transplant is just harder. When in fact the reality is, no, in fact they have many contraindications for a transplant, and you know that yes, you may refer them, they're probably going to be declined, and you have a sense of what their prognosis or what their survival is going to be on dialysis. So there can be discordance in terms of what the patient's understanding is and you as a clinician, your predictions. So hopefully along the way, those two can come together. The perspectives can come closer together. And certainly after a hospitalization, or if there's complications that are related to dialysis itself, they have central venous catheter related sepsis. They then go on to develop endocarditis, and they need a valve replacement. And I mean, that is a very good time to have another serious illness conversation. They have dialysis access issues that causes a transition of care. Suddenly they can no longer do peritoneal dialysis because they had severe refractory peritonitis and had to have their PD catheter removed and transition to hemodialysis. And now life looks very different. And then finally, consideration of dialysis withdrawal. If a patient is indicating by way of language and behavior, expressing some fears about what's to come, that they may comment to their primary in the hemodialysis unit that they just can't do this anymore. They've given it all they can, and they don't have any more steam, any more gas to carry on. That their burden of suffering is just intolerable, and they're considering stopping dialysis. Next slide. So this is an example of a quality metrics graphic, and you can see that what's illustrated is a timeline from late March 2018 right up until late September 2020, which was our last reporting period. There are 6-month reporting periods, and we illustrate all of the various modalities, including CKD GFR less than or equal to 15. And so you can see what's happened with our advanced care planning module data capture over time. And what is heartening is that, as you can see from, I would say March, well, certainly March 2020 until September 2020, there has not been a big downslope, which is what we might have predicted, because something called the pandemic did make conversations challenging for so many reasons in so many ways. There's less face contact, for instance. It is definitely more time consuming to have these conversations using virtual care platforms. And so we have not seen a downsloping. In fact, commendation goes to those in the community hemodialysis units. And one specific example that I would like to acknowledge is Dr. Bev Jung has taken our data entry sheet for advanced care planning, which our committee, our working group developed, and she's taken that to her community units and really been involved in knowledge translation around, use that as a tool to improve data capture using the Promise ACP module. So many thanks to Dr. Jung for moving that work forward in her workplace. Next slide. So how do we pivot? How do we meet the challenge posed by the pandemic, realizing that now is not the time to fall short when it comes to having serious illness conversations? After all, some of our patients may be faced with a life-threatening illness on top of their chronic illness. So things are really compounded. And, you know, James Downer, who's an intensivist and palliative care physician, published an outstanding article in CMAJ very early on. This was in the spring, and it was entitled Pandemic Palliative Care Beyond Ventilators and Saving Lives. And I would invite all of you to read this. It's really outstanding. And just to quote directly from his publication, the COVID-19 pandemic will likely, I would say, is straining our healthcare system beyond capacity. We see that now in the surge happening wave. Palliative care services will be needed across all care settings, including the ICU. And I'm very proud to work in a place where our palliative care physicians readily come to the ICU to perform consultations to help with end-of-life transition. Failing to provide Canadians with effective palliative care would compound the tragedy the pandemic has already caused worldwide. The tragedy we want to avoid is that patients who choose not to have life-sustaining treatment or are denied due to overwhelmed resource capacity are not provided optimal symptom control, and their psychosocial supports are inadequate. They die at the wrong time, in the wrong place, and alone. And so I experienced this really front and center a week ago when I was the only individual that my patient knew well, that we had a long-standing relationship. I felt honored and privileged to be at his bedside as he had administered. His closest friends from Pender Island could not make it over in time, and it was tragic. I was so grateful that I could be there. He otherwise would have died alone. Next slide, please. So how have we customized some of our resources in the context of the pandemic? So in the spring, we composed a letter with input and feedback from patient partners as well. And it related to how important it was to document goals of care given our current situation. Just inviting patients to reflect on what their wishes would be and to ensure that their care providers knew what their wishes would be in the case of a sudden change in their health status. And again, thanks to Sarah Thomas for developing guidance for implementation of COVID-specific advanced care planning discussions. And there are other resources one can find online. I believe they're in a subsequent slide. And so on our website, these can be found if you hit the health professionals tab and then clinical resources and then go to palliative care. And again, this is what the pamphlet looks like in terms of frequently asked questions about stopping dialysis, just to refresh people's memory as to what it looks like and how to access it. Next slide, please. So what are some of the challenges posed specifically? So virtual visits and physical distancing. So we've all been privy to trying to have a conversation with a patient in an in-center or community hemodialysis unit for that matter. And there's just an obvious lack of privacy. And sometimes with virtual visits, depending on the type of relationship you have with your patient, we risk losing sensitivity and authenticity in our conversations. And then we must really take sometimes a different approach for our Indigenous patients. This calls on us to be very sensitive to their needs, because many may have gone through previous pandemics and experienced very tragic losses within their family networks. And we need to approach this with a trauma-informed lens. There's lack of time, that's always a challenge. And there are some challenges in terms of engaging all members of the healthcare team simultaneously, but thanks to Zoom, we've been able to, sidestep this challenge in many cases, really. The no visitor policy, honestly, is a source of great moral distress. And, again, referring to the fact that patients may face end of life alone, this is influencing their decisions around where they want to die. So many now are somewhat impulsively demanding that they be discharged to die at home without adequate home supports to enable a comfortable death at home. So and it really centers around the fact that if they die in acute care, they won't be able to have all family members that they want present to be at the bedside at time of death. But I would encourage all of you to do what you can to negotiate this with CNLs and other staff. I mean, if the rules are the rules, we must obey them to protect everybody, of course, but hopefully we can take a balanced approach. Next slide. So the service model of care delivery can pose some unique challenges as well. So the nephrologist who's on service may be meeting a patient and family members for the very first time. And, they're looking for direction from the primary nephrologist with whom they have a long-standing relationship. Trusting relationships take time to establish, and there may be discordant messaging from other clinicians if there are many specialists involved, for instance, and this can lead to confused trust. So some practical tips we've learned along the way is really just to take that extra time to ask what's important to the patient and to take the time to connect with family members. They really appreciate it. And sometimes it's not a long period of time that it takes, a 5-minute telephone conversation to provide an update and share what the patient has just shared with you can be really important. Communicate clearly and frequently with the interdisciplinary team as well as other physicians, and include the primary nephrologist and include the primary care physician if there is one who has a long-standing relationship with this patient as well. Remember to maintain the art and the humanity in our practice. Next slide, please. And so this is very timely to present once again. So this was mentioned in May, and the gratitude to Doctors Rachel Carson, Brian Forsley, Nina Preto, and all the other authors on this work, and it's actually come to fruition as a publication that is in process of being reviewed and is very close to being accepted. And really the purpose of this was to assist dialysis healthcare providers in determining what type of care each patient will receive in the event of a pandemic, specifically when the need for staffing or other resources may exceed available supply. And I would argue we're there right now. And the scope of this framework is for the adult population. It focuses on hospitalized patients with acute kidney injury in both critical care and non-critical care locations, But we also acknowledge that, and this is unique in our work, that there's a significant impact on our chronic HD patients that must be taken into consideration. And a robust ethical framework is utilized to guide our decision making in this regard. Next slide. And this is the title of our paper that we have submitted to see Jason, balancing the needs of acute and maintenance dialysis patients during the COVID-19 pandemic. I want to acknowledge all of the authors listed and others meaning you know, various kidney care providers that were involved in the working group and our patient partners as well. Next slide, please. Now, symptom assessment and management, we've recognized that there's definitely room for improvement here. And I want to take this opportunity to present our improvement project that Helen Chu is spearheading. What is our goal with this? And we want to reestablish the focus on our goals and the process instead of simply using a tool and simply using that tool to capture data and publish metrics. We want to steer away from that focus and get back to the original reason that we came up with this process. So we want to relieve symptoms that are generally underreported in patients with kidney disease. And there are many publications that demonstrate that underreporting phenomenon. We want to ultimately improve their quality of life. And in terms of the provincial support for this, I've already mentioned there's the PROMISE module, and we can now trend in individual patient symptoms over time to support their care management. There are algorithms for treating symptoms. There's the online training module for MDs and staff, and there are also symptom guides for patients. And this is a screenshot of what it looks like on our website, and that's how you can access it by simply clicking on the Health Professionals tab, Clinical Resources, and then on to Symptom Assessment and Management. Next slide. So why do we use this tool that is called My Symptom Checklist? So what is it exactly? It is actually a standardized tool that's been validated in patients on dialysis. It is recommended in our end-of-life framework, and it's a patient-reported outcome measure that aligns with accreditation standards. It's available in multiple languages, including Punjabi, French, traditional, and simplified Chinese, as well as English, of course. And we are wanting to focus on what an individual patient is experiencing and the trending over time, and importantly, the impact of what we do in terms of their symptoms over time. We hope that we are helping to improve their symptom burden. This may not always be achievable, but our patients have given us input and feedback that, quite consistently, they report that they want to be asked about symptoms, they want to be listened to, and they want us to be honest. It may be the case that we've tried and tried again to fix their restless legs and have sort of reached the end of our options in terms of treatments. And, we are just honest with them and say that we've really tried, and we can't always achieve success when it comes to certain symptoms, but they are comforted by the fact that we are trying. Next slide. And this is just a graphic representation of our quality metric in terms of our provincial uptake of routine symptom assessment using My Symptom Checklist over time. And again, looking at the various modalities. What is interesting to see the correlation with the implementation of virtual care platforms in kidney care clinics and home dialysis clinics. And we believe that this is a reason for the downswing when you look at the blue and the orange lines there. So, and we have heard from many care clinicians about the challenges. Next slide, please. So, improvement project regarding symptom assessment and management going to focus on, well, our goal is to enhance awareness and support the integration of routine symptom assessment and management using My Symptom Checklist to optimize quality of life for patients living with advanced CKD. Next slide, please. And we asked all of the health authority renal programs to report on their experience using My Symptom Checklist, what some successes have been and what challenges have arisen. And what we learned from representatives that are on our palliative care committee is that this is actually implemented in all kidney care settings, and it follows the patient along their illness journey. And it helps to identify and monitor and trend symptoms. It may assist if aligned with medication management in terms of helping to modify medications such that we're tailoring therapy to improve symptom management. It activates the patients in their own care. And many said that it helped them to connect on a personal level with patients and to help them understand what matters most to the patient. And this aligns with patient goal setting. And there's been very significant and successful work with respect to patient goal setting that, again, Helen Chu has spearheaded with many patient partners who have been helpful in that project as well. The challenges have been that people are getting so focused on just using the tool, and instead of recalling why we're doing it in terms of the process. It's difficult sometimes to embed it in our routine workflow. It takes extra time. There's sometimes challenges with internal communication. So perhaps, for instance, it's completed by the patient, we have it, but somehow it doesn't make its way into the promise module for data capture. There are time constraints with many competing demands these days. Some believe that some symptoms may be beyond the nephrologist in terms of being within our area of expertise, and then integrating this into virtual care is an ongoing challenge. Next slide. So we want to get back to focusing on the process, and my apologies for the very fine print here, but this is just an example of a process flow chart. And we have a working group that we've developed. We had our first meeting earlier this week with our patient partners, and I'm just so impressed with our patient partners in terms of how engaged they are, and they're very passionate about this work, really. And so they will be very significant partners in terms of guiding where we should go with this. And questions that we're asking ourselves and other care providers is, how has the process changed patient care? Has it improved it? What has been challenging about the process? And what can we do to support each other in advancing person-centered care through this process? Next slide. So we're talking a little bit about culture change. It does take time, but we believe it's possible. We want to really focus on the common goal, that being to improve quality of life for our patients. Integrating this with existing workflow is really key, and it's contingent on engaging passionate multidisciplinary teams on the front lines. And this is just a quote from one of our patient partners. as to how he felt as he was working within our palliative care committee over the years. And he felt that the accomplishments that to date have set the foundation for alleviating some of the challenges faced by kidney patients. And we, the committee's patients and healthcare professionals, are working together to deal with the important patient issues that haven't received sufficient focus in the past. And that was a direct quote from him. And we hope that what the indicator report will do is to enable progress and improvement over time, and that will embrace challenges and find ways to overcome these challenges during the pandemic. Next slide. And so I'm getting towards the end here, and I would be remiss if I didn't at least mention the fourth pillar, that being grief and bereavement. Now, we as kidney care providers, we are facing our own grief in this time. We are experiencing moral distress, and there was an excellent presentation given by Dr. Jawani for BC Kidney Days related to moral distress. And so this is an infographic that was developed and launched by Canadian Virtual Hospice. And it was distributed widely on National Bereavement Day, which was the third Tuesday in November. And there's actually a new module that's part of, it's called mygrief.ca. And this is covering topics like understanding and moving through grief, how losses affect you, managing intense emotions and difficult situations, and also attending to our self-care. I feel like, you know, what I'm sensing in my frontline care is there are many individuals who are experiencing exhaustion, just utter exhaustion. There's no gas in the tank, so to speak. And they're trying to still maintain their care for their patients, and they're clearly for themselves. And it's my hope in just bringing this to the forefront that this is a resource. Please use it. Please find ways to care for yourself and work through your own grief journey. Next slide, please. So in summary, our progress has been foundational as far as palliative care, renal palliative care in BC. It offers unique opportunities for pivoting activities to focus on what matters most to those we serve. More than ever, our patients value relational, continuous, consistent, and ethical care. And integrated palliative nephrology paves the way for person and family-centered kidney care. Next slide. I think that is the end, yes. So these are, this is our website. Please refer to it. It's an excellent resource. Thank you for your attention and for the opportunity to speak.
Thanks, Gaylene, and actually the whole team. Obviously, it's really, you know, first of all, for the work that you have done and are doing, but also for reminding us about all the things that we've all gone through, and how palliative care and grieving for our patients is one thing, but also appreciating and being kind to ourselves in terms of all the things that people have gone through over the last 6 months is also important. I'm just wondering if there are the participants on the call, if there are some comments or thoughts that others have. Just Brenda, you can let everybody have the ability to be on, so I don't have to unmute anybody. But maybe I'll ask while I'm waiting for other comments or thoughts. Gaylene, you know, there are huge challenges in the current era with more and more distancing, if you will, never mind all the PPEs, and trying to have these conversations and keep everyone sort of up to date with various people's thoughts. And I'm just wondering if the team has come up with, I don't want to say shortcuts because that's not what I mean, but sort of ways to help us not burn out and yet do the right thing for the patients and stuff. I'm just wondering if you want to comment on that.
Thanks for asking that, Adira. It's very relevant, and some practical tips I, along with my team members, have learned along the way is that it's important to identify some close circles. I call it the circle of loved ones. So identify one person, because it is extremely time consuming to be fielding multiple calls and you know, repeating the same update over and over again. So be clear and hopefully there's an identified representative who can share the update with other family members. Identify who the consistent care provider will be providing updates, but also have a backup. And the backup is, the role is to step up when the primary care provider is feeling low in energy, low, just perhaps maybe not in a good headspace. So these are contingency plans to help support each other. And we have to pace ourselves too, right? And sometimes using the good old-fashioned telephone is what we fall back on.
Great. I guess, so there's a couple of questions in the Q&A, so thank you everyone. So one was, how do you convince patients to go the palliative route if they disagree with your assessment? That's an interest, I mean, this is our age-old problem.
Yes. So I long ago learned it's this type of thinking is actually not truly respecting patient dignity. Because if our modus operandi is to convince them to change their mind, we're not going to be successful, for one, and it can really tear apart your established relationship with this patient. So take a different approach, and use the opportunity with your communication and your conversation to just simply find out what matters most to this patient. Try to determine why they're clinging to life by their fingernails. Don't ask, you won't learn.
I think that's a great, I think you're right. Like, you can't force people to do something, but you have to understand where they're coming from, and that's helpful. One last question. So first of all, lots of, in the Q&A, lots of kudos to you, all the members of the team, and everybody really commenting on the excellent work and presentation. And the last question from Dr. Kareem is, are we any closer to assessing quality of dying, and have we made progress in regard to cultural differences in how we approach them?
Thank you so much.
Yeah.
Yeah. So yeah, I regret. I'll tackle the second question first. I regret to say that we have yet to make some inroads in terms of you know, we are increasing awareness in terms of the cultural differences, but we haven't really made inroads in terms of how we approach them. I can give one example locally in terms of our Indigenous population, and there's a wonderful palliative care physician who works on the Saanich Peninsula by the name of Dr. Leah Norgrove, and she and her team have completed the Journey Home project, and they really increased local awareness around the First Nations perspective on end-of-life care and how we can do better in terms of providing quality of care at death. and grief and bereavement after death. So that's one example. So there are local successes, but we as a provincial palliative care committee we have not yet gone there. But in terms of closer to assessing quality of dying, you know, in terms of a metric or evaluation as to how well we're doing, again, there are published tools to quality of death. We have yet to implement them, but you know, one initial step that we've taken, and we have actually developed a project plan, a preliminary project plan, when the opportunity does arise to embark on this work around the fourth pillar of the framework, that we've engaged with a patient partner. Her husband was a patient of mine who died 2.5 years ago, and she has become a very close friend and mentor to me. She spoke at our virtual face-to-face palliative care committee in mid-October, and she gave a powerful presentation on her perspective as a caregiver and the grief journey that she is still going through. And it was very illuminating. So those are initial steps we've taken as a committee to really raise awareness about the importance of undertaking this work.
So thanks very much, Gaylene. And it is 5 minutes after the bottom of the hour, and I very much appreciate, as I said, you taking the time to prepare the presentation, but more importantly for you and all of the people around the province who participate in an ongoing basis in developing and encouraging the framework and the tools, because otherwise they're just words. And I think that with all of that development and so-called socialization of it, I think we're all not only more aware, but more able and more capable of having meaningful and good conversations with our staff, our colleagues, and our patients. And I think together, that's how we change the culture and make it one that is respectful to all with the best outcomes. So thank you to you and your team for reminding us to stay human and to stay grounded, and have a great day, everybody. Thanks.
Thank you very much.